So the diagnosis for all these MPS and ML disorders is difficult. These are rare disorders. The average pediatrician has not seen them. And many of the early manifestations are things not unknown to families. Ear infections, maybe slight developmental delay, minor things. And a pediatrician may not have the perspective of seeing a syndromic disease. They see an issue, they'll get you a referral. So most families will be able to tell you a story of multiple referrals over potentially years. A diagnosis of developmental delay, autism spectrum disorder, all of these sorts of things. And it won't be until years after they have known something is wrong that they finally get a referral to someone who is able to evaluate them from a medical genetics perspective. Once you get in the medical genetics door, so to speak, using either a metabolic screen or a genomic screen, generally speaking, the diagnosis will come forward. But relative to the first onset of disease, we are seeing clinical diagnosis delayed by years. I think in San Filippo, the syndromes that I worked on most when I was in research, the average diagnosis was around 6 years of age. And we think, we're not certain yet, but we think that the window to treat these effectively may be in the severe forms somewhere between 2 to 3.5 years of age. So that's a tough nut. We cannot rely on clinical diagnostics. And we probably don't have a well enough oiled national healthcare system to identify these through clinical diagnosis. Really, newborn screen is the approach that would be most helpful. Now, newborn screening, based on dried blood spots, they will do an enzyme assay using mass spectroscopy, which is extremely sensitive. And then they can follow up on those individuals who have very low enzyme activity to look for the substrates that are stored. These are lysosomal storage diseases. They store a class of substrate called glycosaminoglycans. These are carbohydrates that decorate proteins that are critical for structural issues in our bodies and cell signaling. Newborn screening technically is fairly straightforward. However, every state lab is responsible to conduct this screening. As we all know, coming out of the recent pandemic, the stresses on public health infrastructure are not small, and getting a new disease diagnostic on a newborn screening panel is not trivial. In most cases, it needs to go through a state nomination process. That may have to involve economic modeling. That may also have to involve approval from the state to pay for it. Once the decision is made, if the equipment is there, it's not too much a burden technically to add a new diagnostic on if they're using a similar approach. If they're not using a similar approach, there is a need for equipment, and that may, and technical, there is a need for equipment and technical support, and that may require a year or two extra. But again, part of this is getting the states to approve it. The federal designation of a disease on the recommended uniform screening panel, again, as I had mentioned earlier, that is just a recommendation. One of the big benefits recently is we have had a push of states to adopt what we call alignment legislation. An alignment legislation is legislation at a state that says once something is approved as a disease diagnostic on the RUSP panel, our state will start testing for it. Now that sounds like a great thing, and it is, but there are also levels of goodness, so to speak. There are the RUSP alignment legislations that say this test has to be done 18 months after it goes on the federal RUSP list. No questions asked. There are other states that say within 12 months, this needs to be evaluated by an advisory panel that oversees newborn screening in our state. And if they don't decide to add it, they need to report to the state legislature. If they do decide to add it, we need a report within 18 months of their approval. So there's a process. Hopefully it will go through, but it is not necessarily automatic. So there's still need to support these states, even if they have RUSP alignment. And then, of course, there's a need to get more states enacting RUSP alignment. I think what we'll see in the coming years is an increasing number of states developing RUSP alignment, but I'm afraid there are going to be some small state holdouts. I don't want to say holdout as if it's a bad thing. Smaller states are not going to have a large population. They may not view the risk of one of these diagnoses as being very high. I think we need to try and figure out as a nation, how do we incentivize or how do we reduce the burden for those small states in terms of population to test fully. I don't know what the answer to that is, but I think that's going to be one of the more nettlesome lasting issues when it comes to thinking about universal screening being adopted throughout the country.